Morning. How's everybody? Looks like we've got a few in the group already. Good. Welcome back. Monday morning again, 10 o'clock. We've got along the ticker on the bottom there, covering the spinal tracts again, and then going into sciatica. So yeah, some fairly heavy weeks coming up, but hopefully all of the stuff we've done on the lumbar spine anatomy will start to make this stuff make a bit more sense. The areas of the body where they're affected and the reasons why they're affected, and we'll kind of intersperse things with a few of the anatomy videos as well. Hi Neil, welcome back. Yeah, you might notice we've got a couple of little pictures here. So we've got this chap always comes out. So we've got, I think there are about 6 or 7 places left now on the anatomy visit in King's College, and the same in Kiel as well. Yeah, if you're interested in joining me in the labs, then you can go to learnanatomy.online and you can book in there. Morning, Al. This one here, if you want to get your phone out, this is a QR code, and if you scan that QR code, it will send you straight through to a website where you can win a level 3 sports massage course. So it's a pretty big prize. It's worth 1,500 quid, and we've recently we were talking about it a little while ago, a few episodes ago, about writing a new level 3 course that incorporated a lot of pain science. And then as well as doing the course, you also get access to Learn Anatomy online. So everybody who joins up will get access to this to hopefully help them with their anatomy training for their sports massage exams. So we've got Al up in Liverpool running a course. We've got a new course coming on the south coast, so that'll be coming quite soon. And then we've also got me in Birmingham, and we've got one coming up in Scotland as well. So we've got a few courses in the pipeline. So if you know somebody who might be interested in learning sports massage, you can scan that QR code on your phone, just use your camera, and it should pick it up, and then and give it to a friend if you're already qualified, and then they can enter that competition. If you miss it, you're like, missed the QR code, don't worry, just go back in the video. You should be able to scan it on the screen, or just let me know and I can send you a link. But yeah, you can use that QR code there to enter the competition. Morning, Julie. Good to see you. Okay, let's get going then. So this is where we left off last week. So we were looking at Tracts. So what we'd looked at so far is where the nerve comes into the spinal cord, and then with the parts it goes through, and specifically in the lumbar spine. So we're looking at those intervertebral foramen where the nerve comes in. In fact, let me just grab a video of that. I've got one lined up for you for a bit. Let me just get rid of some of those. Let's just recap on that a sec. Yeah, so here we go. Okay, so this is a video that we saw a couple of weeks ago, so just a bit of a recap. So we've got the dura, which is the wrapping around the spinal cord, and then the spinal cord in the middle. And if this is all new to you, then go back a few weeks, because we've covered this in some detail. And then we've got these rootlets that come off the spinal cord, and then they form their nerve roots. And then the ones at the back are the sensory nerves, so they're the dorsal roots. The ones at the front are the motor nerves, and we've got these little ligaments that hold the spinal cord in place. And then this is the pathway of those roots, and that's really important when we get to sciatica, okay, and some of the reasons why some areas of your spine are more susceptible to pathology than others. Okay, so there we've got the different roots that we were just talking about. So the ventral root at the front, dorsal root at the back, So that's the cervicals. You can see the direction there. And then in the thoracics, they're a little bit steeper because as we grow, those nerves get stretched. And we talked a little bit about this last week when we were looking at embryology. And then this is the chorda equina. So the conus finishes around about L1, L2. So that's the end of your spinal cord. And then the rest of it then are nerves that stretch all the way down into the sacral plexus, which we had a look at a few weeks ago. So it's called a horse's tail, chorda equina, because that's what it looks like. And you can see these roots here. So because of the trajectory of these roots, let me just pause that there. So if you think about the stretch on those roots as they go through those intervertebral foramen, let me just show you this video. Go forward a little bit on it. Here we go. Okay, so we can see the roots coming through there. In the cervicals, there's not much of a stretch, okay, but in where it's the chorda equina, there's a lot of a stretch. So if you imagine the archway of that intervertebral foramen, the nerve coming through is going to be right at the top of that archway, okay, and that will be important when we start to have a look at the pathology. And like I say, some of the reasons why we get the symptoms that we do. So when those nerves go into the spinal cord, there are different pathways that the specific nerves, depending on what the sensation is the carrier for those signals up to the brain. So basically the spinal cord has two principal functions. We covered this last week. So nerve impulse propagation, so basically sending nerve impulses, and then the integration of information. That's basically what the spinal cord will do. And then we talked about these tracts. So sensory input travels along these tracts towards the brain. So it's the information's coming in from the external environment and your internal environment. So all of the receptors in your body, so around your joints, on the organs, or everywhere, as it is full of sensors, and they're always feeding information back into your spinal cord and then up to the brain, to the relevant areas of the brain, to let your brain know what's going on with your body. And then depending on what information it receives, the brain then sends motor signals down the spinal cord through different tracts, through different pathways, and then they switch on certain muscles or glands or whatever it is. So the sensory input travels up, the motor impulses travel from the brain down towards the muscles or the organs, and then the names of the tracts tell you which direction they go in. So we briefly covered this last week. So anterior means it's at the front. Corticospinal means it goes from the cerebral cortex, so the cortico part of the brain, down to the spine. Okay, so corticospinal tract. So it's at the front from the brain to the spine. Okay, so the names of the tracts sound really confusing and really long, and sometimes they might still do because you don't know the areas of the brain. But that is the reason why they're given those names. So hopefully you'll be able to work those out when you see them. So what the brain is trying to do and the nervous system is trying to do is maintain a homeostasis. So we've got this sensory input coming in and then the motor input coming out, and then everything remains balanced. Okay, so that's the idea. And then this picture I showed you, so same Dave is the way to remember the different names of the pathways of the nerves, because we've been using motor and sensory as our terminology, as our nomenclature, but sometimes they're called afferent and efferent, and that can be really confusing, or affectors and effectors. Okay, so the way to remember that is same Dave. Okay, so sensory is afferent, so they basically mean the same thing. Okay, motor is efferent, so same, and then dorsal is afferent, so that's the dorsal, which is the sensory part, and we've been talking about that already, and then ventral is efferent. Okay, so we've got sensory, afferent, motor, efferent. So that we've been using sensory and motor so far, so bringing in a couple of new terms. And then the dorsal part of the spinal cord, or the roots coming out of the spinal cord, are afferent, and the ventral, the front parts, are efferent. So if you remember to David Beckham, same Dave, then that should hopefully help you remember those the differences. They're exactly the same, but they are used interchangeably. So some people in the research literature or in textbooks might only use afferent. They might not use sensory, and you're thinking, what the heck is an afferent nerve? And now you know afferent sensory. Okay, so there you go. So that's that one. Lots of confusing things like that. And then we finished on this last week, and hopefully I'm going to make this picture make a little bit more sense. So I've tried to add loads of arrows on and highlight certain areas for the ones for you to concentrate on. So this image is from the book, I think it's called Principles of Anatomy and Physiology by Tortora. It's like a gold standard textbook for anatomy and physiology. And this is a usual image that you'll see, but I've put these arrows on and I've highlighted certain areas here. Okay, so these ones that I've highlighted, so these two blue boxes and that red box there, these are the main areas that are important for neurological testing. So if you are a therapist and you think that someone might have injured some part of their nervous system or muscle or whatever it is, then depending on the symptoms that they get, you might do a neurological exam. It depends on what you've been trained to do. But or you may have had a neurological exam done on you, so it may be a reflex test, or someone's tested the sensation in your skin, or whatever it is, and you're thinking, why the heck are they doing that? What's that for? Well, hopefully after this bit you'll realize what it's for, and I'll also show you when it can go wrong, and the kind of things that you might see. So again, we talked about this last time. So if you think about a sensation on the skin, so something's sharp that you've touched, so there'll be some sort of afferent nerve, so a sensory nerve that will it will reach a certain threshold level. There'll be enough of a stimulus to activate that nerve, and then that will then propagate, so it will send impulses into your spinal cord, and then depending on what sensory receptor it has activated, so that depends on the touch and the sensation, that will then go up a certain tract in your spinal cord. Okay, so if we have a look at these ones that I've got outlined here, so we've got spinothalamic tract, and then we've got the posterior column. Okay, so these two are two crucial tracts for neurological testing. Okay, so if we use the same process that we did for the anterior corticospinal tract, the spinothalamic tract goes from the spine to the thalamus. That's why it's called spinothalamic, and that resides in this part of your spinal cord. Okay. Now, there's all sorts of stuff that goes on. It's not just like well, sometimes it is, but sometimes the signals go up a couple of levels and then it will switch across and then go up. So it's not as easy as it goes in through one bit and then straight up to your brain. Yeah, there's all sorts of other things that go on. Not my area of expertise. You can do like PhDs on just one tract. Okay, so I know that there is a spinothalamic tract, and that's all I need to know. Okay, so you don't need to worry about too much of the detail of where it goes afterwards. But what we need to know is what it looks like when something's wrong with that tract. Okay, so that's the key thing, and then the posterior column is obviously at the back. So that's and it's obviously mirrored on both sides as well. So we've got a spinothalamic tract on one side and on the other side. But just for the ease of this drawing, they've only done descending pathways this side and ascending that side. So the lateral corticospinal tract is lateral, so it's on the outside from the cortex of the brain down to the spine. So this is an descending tract from the brain, okay, because it's going from the cortico part of the brain, so the cerebral cortex, down to the spine. And again, that will be mirrored over here. Okay, so that they'll be on both sides. Cool. So that's the first bit. And these are this is the sensation that is interpreted or sent along these different tracks. So it's interpreted by the brain, but sent along these tracks. So if you touch someone really, really lightly, so with a cotton wool, piece of cotton wool, then that will it will stimulate the sensors within the skin that detect light touch, and that will reach a certain threshold level, and then when it hits the spinal cord and goes in that dorsal part of the nerve root, it will travel up the anterior spinothalamic tract, so going from the spine to the thalamus. Okay, so that light touch is sent up that particular tract. Okay, sharp touch, so if you jab someone with a we use what they're called neurotips in the clinic, so like something with a very sharp edge on, you jab that on the skin, sensation will be detected by the sensors that detect sharp touch, and that will be sent up, that information will be sent up the lateral spinothalamic tract, so separate to light touch. So sometimes you can lose sensation with one type of touch, but you may not lose it with another. Okay, so this is why we need to test all these different things. So if you only test light touch and that's it, then there may be a problem with the lateral spinothalamic tract, and because you didn't do sharp touch, you haven't tested it. Okay, temperature sense. So what we do there is we use hot and cold water, and in test tubes, and warm rather than hot, and you try to see the difference between the two. So you'll place something on the skin and you'll ask someone whether they can feel whether it's hot or cold, and that information will be traveling up this specific tract. Okay, so sharp touch and temperature are these is the same. Light touch is a different one. Okay, vibration sense. This is a really important one, especially for balance, and usually one of the first ones to go in diabetes is a vibration sense. So you get a tuning fork, you ping the end of the tuning fork, and you place that on the big toe or the fingers, on the ends of the fingers, to see whether the person can sense vibration through those toes or fingers. And that information, that vibration sense and proprioceptive information, is sent up the posterior column. Okay, so if we go back to the previous slide there, so this posterior column here, that is where your vibration sense information will be sent up to the brain. Okay, so detected on the skin and then sent up to the brain via that posterior column there. Okay, so those are the key things that we would test in sensation for a neurological exam, right? And those are the tracks that they go up. Now, depending on whether something is dangerous or not, you may have an instant withdrawal from a specific stimulus, and you would have heard of this as a reflex. So if you step on something sharp, then immediately that sharp touch is picked up by the sensors in the skin. The information travels up the lateral spinothalamic tract to the brain, but instantly there will be a neuron that specific sensation will kind of group with, and there'll be an interneuron within this matter here that will activate a motor neuron to move your leg out of the way. Okay, so and that's like you probably would have had that done at the doctors if someone like bangs your knee or something like that. It's a different type of reflex, but the withdrawal reflex, something sharp, something hot, immediately you will activate that reflex action, but also the information is sent up to the brain to let the brain know what's going on and that you've just stepped on a pin or whatever it is. Okay, so that's all happening. Right, let's just move that there. Yeah, so different tracks are activated depending or used depending on the information being sent down as well. So these are the motor tracks. So voluntary movement, so ones that you consciously control, is sent via these tracks here. Okay, so lateral corticospinal, anterior corticospinal, and then corticobulbar. Okay, so those are the three main voluntary tracks, and you can see those on the pictures here. We don't really need to know that. That's a kind of nice to know information. We wouldn't be able to determine where the problem was if there was an issue with those. Involuntary contraction, so autonomic nervous system, travel down these tracks. So there are separate tracks for your automatic system, so digestion, breathing, heart rate, all that kind of stuff, compared to voluntary movements of skeletal muscle. Okay, so that they are separated. So what do we do then when we're in doing our testing of these areas? If you test a muscle, it's called a myotome test. Okay, so myotome is basically, myo means muscle, and then a tome is a section. So it's a section of the spine that innervates a specific muscle or group of muscles. Okay, and yeah, there are some. There's a lot of crossover with different areas of the spine. So if you have a problem with one of the nerve roots, then another one may pick up the slack because there's a bit of a crossover. It might be a bit weaker, might feel a bit weird, but you'll still be able to do the movement. The place where that doesn't happen, because there's only one area where it is innervated by, is dorsiflexion. So obviously this is important for the lumbar spine because your tibialis anterior muscle, so way back on the foot and ankle, is innervated by your L5. Okay, so the motor nerve coming out of L5. So if you have a problem there, it will switch off your dorsiflexion and you'll get something called drop foot. Okay, so there aren't any other crossovers in that area. It's just that one. So if you have a problem there, then you won't be able to lift your foot. Right, so and that's a classic problem with the lumbar spine. So a myotome then is a muscle or group of muscles that is innervated by a single spinal cord level, and we're focusing on the lumbars at the moment, but this applies to everything. So when we test myotomes, we're testing motor integrity. And again, if you've not heard this before, this is basically like doing a strength test. Okay, so very rarely do you get people other than in hospital that can't contract their muscle at all. Okay, so if they literally can't, there's no palpable contraction. That's a 0 out of 5. So we grade it out of 5. Okay, it's something called the Oxford grading scale. If you can get a little bit of contraction but no movement, then it's a 1. A movement with gravity eliminated. So rather than lifting your arm up whilst you're seated, you might lie on your side and do it, and that takes out gravity. Then that would be giving you a 2 out of 5 if you couldn't do it against gravity. And then here, 5 out of 5 is you're able to move against gravity with full resistance. So you push on their limb, they contract into you, and they can do that contraction and sustain it. Then they get a 5 out of 5. Okay, so that's how we test the muscles. So in the lower limb, there's a sequence that you can go through to test all of the nerve root levels of the lumbar spine. And this is that. So this is the upper extremity. So we'll cover that a bit more when we go into the brachial plexus. But for what we've been covering over the last few weeks, this is how you test it. So for hip flexion, that tests L2 predominantly. Knee extension is L3, so the motor nerves coming out of L3 provide the innervation for the muscles of knee extension. Ankle dorsiflexion L4, hallux extension L5, knee flexion S1, S2. Okay, so in fact that one's not quite right. Yeah, so there's with the ankle dorsiflexion, that it depends on how you test it and which book you read. But yeah, if you have drop foot, then usually there's a problem at L4, L5. Okay, that nerve root level. So hallux extension, so extending your big toe is L5, so you can lift push against the big toe, and then knee flexion, bringing your heel towards your bum, S1, S2. Okay, so that is how you would test broadly all of the nerve root levels to see whether the motor nerves coming out of that area are functioning correctly. Okay, so that's myotone testing. Then you can go into, oh, I think we did dermatomes before, didn't we? Dan's just made a statement, I think, rather than a question. Let's have a look. Yeah, so Oxford scale is presumably what MKT and muscle manual testing is attempting to reason with and say healthy people have issues with strength, but MNTs were constructed for people with polio. Yeah, so you're looking at these measurements, people being really badly injured, especially down here. Yeah. Usually people come into clinic or into a gym and they're 3 out of 5. Okay. And if they are lower than that and they can't contract, it's usually because of pain rather than a problem with the supply to their nerves. Yeah. So really looking for motor nerve function, not screen people. Yes. Yeah. That's what these are designed for. Yeah. So we're looking at motor nerve function rather than a screening test. Yeah, definitely. Cool. Okay. So that then leads us into a little bit on reflex testing. Let me just show you this. So when we do reflex testing, we're testing the integrity of the whole system. I'm just going to bring up a video here. So when you hit a tendon, that tendon detects a stretch within the muscle. And when that muscle is being stretched, a signal from those stretch receptors in the muscle is sent to the spinal cord. And we covered this a couple of weeks ago, maybe last week. And then once it goes into the spinal cord receives that information and goes, your muscle's being stretched really quick. Okay, so immediately it will activate a motor neuron to contract your quads to stop your quads from being torn. Okay, so that's the whole point of a reflex action, or this tendon reflex. So when you hit the tendon, the body thinks that you've rapidly stretched that muscle. So the stretch receptors are elongated. That is then picked up by the spinal cord, and then immediately you contract the muscle to shorten it so that it doesn't get overstretched. Okay. At the same time, there is a message that gets sent up one of the tracts up to your brain to let your brain know what's going on. All right, and that happens in milliseconds. This is what happens when it goes wrong. So let's just have a look at this. So this is a chap who has come in and he's got a bit of weakness in this right leg. There is no audio on it, so I've put on some key statements on the side there. If you type in clonus, CLONUS, into YouTube, then you should be able to come up with this video. This is a really good example of when things don't go quite right. So his history, he's had a cervical surgery for something called a stenosis, which is a narrowing of C5 and C6. So he's had those areas fused. So he's got this issue with his neck and his spinal cord. Okay, and that's really important. So he's going to test his reflexes now. And this is obviously upper body here. So because the problems with the lowers, he's testing the uppers first. So triceps is C7. Biceps and brachioradialis is C5, C6, so he tests those. Does the other side as well, and he's pretty springy. Okay, so you test the other side to compare. Like I say, if there's a lower body problem, you test the uppers as well so that you can compare them. And then watch this one. Boom. Okay, really reflexive, and on the Achilles. And now watch this one as he does this one. Okay, and that's what we call clonus. Okay, so if we have a look at what's happened there. So he's hit that patella tendon with a hammer. So this chap has had that tendon stretched really rapidly, which has then been picked up by his muscles. Okay, the stretch receptors have picked that up, sent a message to his spinal cord, and then the spinal cord has sent an immediate message back to the quads to say contract because you've been stretched really quickly. At the same time, a message goes up to the brain to let the brain know what's going on. Now, this guy has had a problem with his spinal cord. Okay, so that information getting to the brain isn't getting there efficiently enough. Okay, on the left hand side and in the upper body, not too bad. For whatever reason, it has affected one of the tracts that comes from the right hand side. Okay, so whatever he's had done in his neck is affecting his reflexes. So what's happening is that stretch has been detected by in the quads. So then he's gotten to contract the quads. So what happens when you contract your quads and your knee extends? Your hamstrings stretch. So that is then picked up by the stretch receptors in the hamstrings, sent to the spinal cord. Spinal cord says contract your hamstrings because they're stretching too much, so they contract. What happens then? Your quadriceps get stretched, so that gets sent back to the spinal cord, and then back, contract your quads, and it just keeps going, boom, 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 and that's what's causing clonus. What happens is in a normal functioning spinal tract is that relay of information is modulated by the brain. Okay, so the brain looks at everything and goes, yeah, that's okay, you just need to calm down, and then it will stop. Like us normal, if you hit your patella tendon, you'll have a quick jerk reflex, and then that'll be it. Okay, but with someone with a spinal cord problem, and this could be like this chap has had, or it could be something to do with the brain, like a stroke or something like that, you will get an increased reflex, and that's pretty significant, that one, because it's what we call clonic, so it's just continuous. So that's what happens when things go wrong, okay, and that is why they go wrong. So if you know about where the nerves go from, you know where they go to, you know how they get to the brain, you can then understand why we have these issues with reflexes. Okay, so just wanted to show you that because I think that's a really, really important video for everybody to see. Cool, right. Let's have a look at this. So, yeah, promised a little while ago to have a look at sciatica. It's something that we deal with quite a lot in fitness world and in the therapy world. I mean, therapy world, absolutely. And loads of people getting diagnosed with sciatica, or Google it, and then they say, oh yeah, I've got sciatica. But what actually is it? So sciatica is pain down the back of the leg. So it's quite a broad term. So we need to be a little bit more specific with exactly what we're looking at. And again, the knowledge that we've had over the last few weeks about the nerve roots and where they all go through, hopefully that will make this make sense as well. So we're going to have a look at three key things. So radicular pain, something called a radiculopathy. They sound very similar, but they're very different. And then something called referred pain. Okay, so those are the three key things that we need to understand when someone has pain down the back of their leg. Okay, or odd sensations or whatever it is. And obviously we're doing the lumbar spine, so this is one of the key areas. So what is referred pain? So there are two main types of referred pain. It basically means the pain is coming from somewhere where the problem isn't. Okay, so if they're getting pain down the back of their leg, it doesn't mean that there's a problem down the back of their leg. Yeah, the pain is coming from somewhere else. So you've got two main types. You've got visceral referred pain, and this comes from organs. And then you've got somatic referred pain, and this is from your bones, your cartilage, and your muscles. So if you remember back to last week, we looked at something called sclerotomes, and sclerotomal patterns is something that you might want to have a look up, because they are referred pain patterns from the joints and from the bones. So if you have an irritation to a sacroiliac joint, or you have got an irritation to the lumbar spine, then that can be detected in those regions, but you may feel it somewhere else. Okay, and there are again, there's a bit of a crossover with patterns, but just because something is down the back of the leg, it doesn't necessarily mean it's coming from the nerve root. Okay, so this is something to have a think about. So it's usually dull and diffuse, whereas with other nerve type symptoms, they're usually shooting and sharp. Okay, so there's a bit of a difference between the two. So one of the reasons why we get it is because of this. I've covered this a little bit before. This is a classic example of a referred pain, and another one is a heart attack. So if you have a heart attack, you feel it in your jaw, you feel it down your arm, usually the left arm. Sometimes it can go to the right. So you have no problem with the jaw, you have no problem with your arm. The problem is with your heart. Okay, so the body is obviously sensing something in the heart, but it's trying to make sense of that information, and it's making it hurt somewhere else, because it's like, well, it can't be hurting there can't be anything wrong there. Yeah, so, and that's what happens with this as well. So this is something called Kerr's sign, and there's a nerve that innervates your diaphragm, and it's called the phrenic nerve, and we'll cover this when we get into the neck. But the little rhyme is C345 keeps the diaphragm alive. So the phrenic nerve comes out of those nerve roots and then onto the top of the diaphragm. And we'll show you a really good video of that when we get to that stage. And that is what controls your breathing. Okay, so the phrenic nerve, and one of the reasons why neck injuries are so dangerous, because if you injure that nerve, it will switch off your diaphragm. Okay. The other thing that can happen is if you have a problem with your spleen or your liver, okay, which sit just underneath the diaphragm, and they start to irritate the diaphragm, the sensory receptors from the phrenic nerve will become activated, and they will send information up to your neck, okay, to C3, 4, and 5. Now, the C3, 4, and 5 nerve roots also supply the sensation of the shoulder. So your body, in its wisdom, goes, it can't be the diaphragm that's causing the problem, it must be your shoulder. So you actually get shoulder pain with liver spleen issues, okay? And it's because of that shared nerve root. So again, now you've had a look at the nerve roots and how all the nerves come in, hopefully that makes a bit more sense. So irritation of the diaphragm is detected by C3, 4, and 5. C3, 4, and 5 also receive sensory information from the shoulder. So the messages get mixed up and your shoulder hurts. There's nothing wrong with your shoulder. You can get this with lung symptoms as well. And I used an example of a patient that I saw who unfortunately had lung cancer, and all they presented with was shoulder pain. Okay? And when you tested the shoulder, moved it around, there were no problems whatsoever. And you did all the strength tests, did all the sensation test, everything was fine. Couldn't get any relief from the pain. That is, well, it was coming from his lung. Okay, so that is a visceral referred pain. Okay, so yeah, just got a question here from Dan. So with visceral pain from organs, etc., chronic conditions such as endometriosis, that is being monitored in theory. Desensitized sensation, possibly for a short time. Yeah, may modulate the pain, but you're not going to sort the problem. Yeah, so yeah, you could get short-term pain relief with manual therapy, but that's another kind of classic is gut problems, endometriosis, fibroids, those kind of things that are irritating the viscera. So in this case, the kind of reproductive or gastrointestinal organs, and they give you back pain. Okay, so it may present as back pain, but actually it's coming from the viscera. So that is referred pain. So something that's coming from an area that is other than the area that is sore. Okay. Then we've got this one, which is radicular pain. And this is quite a common one that gets confused, and we often use the terms radicular and radiculopathy together, and they mean different things. So I'm just going to cover these things, and then we'll catch up with the rest next week. Okay, and if you've got any questions, then you can ask away. So that this is kind of bringing the anatomy into practice, and hopefully this will help you make sense of some of the things that you see. So radicular pain is coming from the nerve root or nerve root ganglion. Okay, and we've looked at those. Yeah, we've looked at where the nerve root is. We've looked at that little bulbous area of sensory nerves, which is the nerve root ganglion. It's usually sharp and shooting, so that's different to referred. Referred is usually dull, diffuse, and you can't really pinpoint it. Okay, this one's usually following a specific kind of line, a specific pattern. And again, these are some of the common patterns and where you'll get altered sensation, kind of classic C8, C6, those kind of areas. That's come from this this paper and that website there. So if you want to have a look at that, then you can. There's usually a clear defined line of pain. Okay, so it's usually clearly delineated, but this is coming from the nerve root. Okay, so there's an irritation at the nerve root. We're going to talk about what irritates it next week, and then you get this shooting pain. There can be referred pain that mimics these. Okay, and this is where things get a bit confusing. Then we've got radiculopathy. So radiculopathy is nothing to do with the symptoms, so nothing to do with the pain. This is to do with function. Okay, so when something has irritated or compressed or whatever, the nerve root, as it's coming out of the spinal cord and through the vertebra, we get a loss of nerve function. So there's an injury at the nerve root. You will have reduced reflexes, loss of touch sensations. That's the stuff we were just talking about before. Loss of muscle strength. Okay, so those are your dermatome and myotome tests that we were just talking about. So if you have a loss of those, that is a radiculopathy. Okay, not radicular pain. It's different. Okay, so radiculopathy is to do with all of the function. Radicular pain is to do with origin at the nerve root, and then referred pain can be somewhere else. Okay, the only problem is you can have a combination of all of them, and this is the problem with the lumbar spine. Well, anywhere in the body really, you can have a bit of a combination of all of these, and they can change as the problem progresses. So you can have a severe radicular pain, so severe shooting pains with no radiculopathy, so no loss of sensation, no motor loss, no loss of reflex. It's just pain. Okay, or you can have it the other way around, where you have complete loss of sensation but no pain. Okay, so they don't go hand in hand. It's a bit of a continuum, and it also changes, and this is why it's so frustrating. The symptoms can shift, and then throw into the mix some referred pain from the somatic system too. So there may be an irritation around the facet joints, and we've had a look at those over the last few weeks. It could be the nerve root, it could be the muscles around there, it could be an area above and below the area that's symptomatic. There are so many different factors that play into this. Okay, so danger messages from the disc. If there's a disc herniation, we looked at that, we're going to cover that again, can cause referred pain. So it's the disc that can give you symptoms as well. Okay, so a certain amount of nociceptive stimulus, and then you get danger messages, and then that then refers down the leg or into the groin or into the buttock or wherever it is. Radicular pain from the nerve root compression and radiculopathy due to the insult to the nerve root. So there's loads of different things that can happen. So it's very difficult to pin one thing down as the reason for symptoms. Is it this? Is it that? We don't really know. Okay, so why the heck is it called sciatica? It was called sciatica even back in William Shakespeare's time, so in the 1600s. And this is how he described it: "Thou cold sciatica, cripple our senators, that their limbs may halt as lamely as their manners. So if you want to have a look at that, it's Timon of Athens. I just dug that out. But it's a very, very broad term. And I used to think, well, it's not very good having a broad term, because you need something specific. Basically means pain down the back of the leg. But maybe that's a good thing, because pain down the back of the leg isn't very specific. Okay, but that can be really frustrating too, because everybody assumes the worst and think that it's some kind of major disc problem, but it might not be. Okay, and that's where your neurological testing comes in real handy. Okay, which is the stuff we were talking about before. Cool. So, a little bit of a dive into sciatica. We're going to have a look next week at some of the ways that the nerve roots get irritated. Okay, so again, recap of the anatomy and the closeness of the structures in that area, and then we'll have a look at some of the symptoms that you can get. So hopefully this is helping in putting some of the anatomy into practice for you. Okay, cool. Have a great week. 45 minutes already, gone really quick. Yeah, hopefully that was okay. Any questions, or if there's anything you want me to recap, then just pop it in the group. Happy to go over some things again. I usually do a recap anyway, but if there's anything specific, then obviously let me know. And I will see you next week. Cheers, guys.